One of my students was having trouble thinking through an AC joint separation case, so let's discuss this. My name is Huang. I'm an occupational therapist and certified hand therapist, and inside the mentorship program, I offer advice and help my students really critically think through their cases and learn what to look for and what to do. So let's dive in a little bit. Let me share my screen so you can see the question. So often I encourage my students to share with me the age of the patient because it really matters, especially in shoulder cases. Age plays a role because if you're over the age of 40, there tends to be more rotator cuff types of issues. And if you're under the age of 30, your patients might be suffering from like just instability. So age makes a difference. Also, age makes a difference in terms of making decisions about what's the next procedure if they need something. Right? So this is a shoulder AC separation case, and she's just wanting help to, kind of think about this is chronic in nature and really think about what am I allowed to do and what should I be looking for? So that's the general question. So take a look. This is a chronic AC issue. Chronic means been a long time coming, right? So they got an injection for they had an injection for the AC joint. To me, if they got an injection, it's usually because they had a lot of pain that they don't want to tolerate anymore. So an injection, once they get a cortisone injection, then in an evaluation, like what am I looking for in an evaluation? In my evaluation, I want to know how many injections have you had, because that will tell me how chronic it is in its nature. So the rule of thumb, right? The general rule of thumb for a cortisone injection is no more than 3 to the same area. So if my patient comes in and they had an injection, I'll ask them, is this your first injection or have you had others for that same area? If they had a chronic issue and they are like, oh, I always get an injection every so often, blah, 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 that means it's really, really chronic. And I'm not really sure how effective you would be at getting rid of the pain unless there's some changes going on, right? And so it's not to say that they won't get better. It's just that you have to sort of think a little bit outside the box and think about like what they're doing that keeps them chronic, right? So yeah, that's really, really important in the evaluation. If this is the first time, great. How long ago was that AC joint separation to begin with? So no decompression was written in the script. So what does that mean? So decompression just means they don't want you to do joint distraction, right? They don't want to decompress that joint. If it's a chronic AC like separation issue, there's a chronic dislocation, then if they're already chronically dislocating, the last thing the doctors want you to do is to stretch them and potentially dislocate them further, right? So no decompression just means that. So there's still some range of motion. How can I prove end range stiffness? So if this is chronic in nature and this is an 80-year-old person, I want you to think about the possibility, like the high possibility of the arthritis that might be in that joint. And that's going to limit how much you can improve in terms of getting that end range and the stiffness. It's not to say you can't get better. Of course you can get better. It's just not going to get better fast. And it's also not always 100%, right? If they have had separation, like that AC joint like dislocates quite a bit, you may want to keep that end range stiffness. You may want to not overstretch them so that they can stiffen, so they can be more stable, right? Something to consider. But he's able to do active assisted range of motion. So that means to me, is he not that strong? Right? So I want to encourage you to think about the chronic nature, right? you have to, if it's chronic, you need to set expectations. Set expectations. We're always frustrated and we're always disappointed when our expectations are set incorrectly. Chronic in nature in an 80-year-old is different than someone who's in their 40s and 50s, and even more different from someone in their 20s and 30s. Age does play a role in terms of how fast you can get something, how fast you can improve, and how long you can keep stuff for. I mean, this is chronic in nature, so I would want to know, like, how long has the chronicity been, right? And if they've had the injection, I want to know effectiveness. So after you get the injection, within a few days, you should feel pretty good if it worked. So did it? Right? I would want to know that. Did it improve on pain? Because if it improved on pain, then there's a higher likelihood that you're going to progress really well. If you get the injection and they're like, it didn't help me at all, then that tells me it's probably not at that site, at that joint level, the AC joint level, that's the problem. Majority of the time, it's going to be, if it's not at the joint, right? If it's not at the joint, then it's at the muscle level, right? It's the imbalance of how the scapula is moving to the humeral head, right? So you don't want to separate, you don't necessarily want to do a joint distraction in terms of like the AC joint. What's the AC joint? It's a acromion, it's a scapula that then is connected to the clavicle. It doesn't have anything to do with the humerus. So you can still do a humeral inferior glide, right? If this is superior and this is inferior, and they keep hitting into the acromion, right, into the AC joint, you can get the humeral head to, you can do some inferior glide, you can even do some posterior glide to make sure that that humeral head is moving the way it's supposed to move, so that you can clear the humeral head and get more motion, right? So you want to do everything in a pain-free range, right? So you want to get passive range of motion, and then you're going to work on active range of motion, and then you're going to work on strengthening, right? Strengthening, and you can do bands, you can do weights, right? You can do all of that. It just depends on what is this 80-year-old able to do. So I can do weights with somebody, but they have to get in side lying. They might have to be in prone. So you have to look at your patient and say, what are they capable of doing? If they're not capable of getting into all those positions, bands might be just an easier method for you to teach them how to strengthen, right? I love getting my patients, I don't care how old they are, I love getting them into side lying, prone, and supine, right? I don't like to do my exercises only in supine. I like to get them in prone, because prone puts certain muscles working against gravity, and it's a great way to making sure that you can see someone's scapular mobility and ability to like move the scapula against gravity. So prone is a really great position. Sideline is a really good position to also work so that you can move the scapula a little bit, right? Make sure that scapula is able to elevate, depress, retract, and protract. Did I do that backwards? Retract and protract, right? But you need that scapula to move. If that scapula is not moving, then you don't really have a lot of luck to move that humeral head in a pain-free range. And the scapula sits on top of the thoracic wall, right? So you've got to make sure that your patients are doing thoracic rotations, thoracic extension. I teach very specific ways of moving it inside the mentorship program, but however you want to do it, you can do it. If you want to come and learn how I do it, then the link's below for the mentorship program. But here I just want to encourage you to think through your case and what you're technically allowed to do. So from a technical standpoint, you're allowed to do everything because this is chronic in nature. What you're not allowed to do is like to facilitate more stretching of an area that is very unstable, right? So you want to make sure you're not overstretching the clavicle to the scapula. So you're not doing a lot of that, like the pec stretch, in the external rotation against the door stretch, because that's just going to facilitate more stretch here where you don't necessarily want it. You want to promote scapular range of motion, and then you also want to promote a certain amount of strengthening so that they could lift their arm in a pain-free range. So what are some ways that you can strengthen, right? What are some ways that you can strengthen that doesn't necessarily include all of that? It's called isometrics, right? Isometrics. So if you position the humeral head, so this is one of my favorite things that I like to do is in supine, you would do a inferior posterior glide, right? If you see that they're very tight forward. Majority of the time they are very tight forward. It's just the way our bodies are made. So I would do a 45-degree position, humerus to body position. I would do a posterior glide. In holding them posteriorly, I would ask them to adduct, right? So I would place my hand there and I would do an isometric adduction, and then I would do 10 of those and then see if that helps them to move in a pain-free range. You can also do in supine. I'll also put them in a 45-degree angle, and I'll do internal rotation or external rotation, and I'll ask them like, hey, which direction feels easier for you? And whichever direction feels easier for them, I will do that direction. So a lot of times, believe it or not, they'll want to do internal rotation because your subscap tends to be a little stronger, and it'll just help them like give their scapula the stability it needs, right? So if internal rotation is really good, here's the thing. If you're doing internal rotation, it should be sub-maximal effort, meaning just give me a little bit of effort. A lot of times people do maximal effort and they're bouncing around a lot. So they're like, and then they let go and they let go too fast. And so there's this recoil or rebound out of it. So I usually just tell my patients, hey, just give me like a little bit of effort, and then they pull in, pull, and I hold it for like 3 seconds and they call it a day. If they're trying to push me over, I'm working that hard, like, you know, or they're coming out of their form, like their scapula is coming up, or their humeral head keeps coming up, then they're trying too hard and they're falling out of the position. So, you know, we're not exercising to say who is strongest here. We're just trying to exercise, but the quality of our movement is just as important as the quantity of our movement, all right? So if you're gonna do isometrics, it tends to be a little bit more technical, so you just want to pay attention to form, positioning, and effort from your patients. But I would do isometrics, and then I would test against the range of motion and see if it got better, right? But those are some of the things that you can do. You can get started with this. And so one of the things that I do with my patients, one of the things that I do with my students is when they send me questions like this, I get them started, and then I tell them, hey, so try these X, Y, and Z out, whatever it is, and I usually refer them, I send them inside the mentorship program to look at certain videos that can help guide how they do their exercises with their patients. And then I tell them to give me a report back, like, you know, after they've seen them for so many visits, so we can then continue to progress. So it's so important to figure out what works and what doesn't work for your patients. And things that work, you might be surprised, and you just keep doing more and more of those. And the things that don't work, it's not that you'll never do them again. It's just that maybe it didn't work at the time that you had gotten them started at. But there's going to be some exercises that you do to help them, but then you give them other shit, and then it throws them out of whack, and then so you feel like you're not getting results, but it's probably just you doing some exercises out of order, and it makes a really big difference in getting progress for your patients. If you work with a lot of shoulder cases and you feel like you're kind of lost and you want to get some feedback, you want to learn more that maybe you're not aware of. It's that idea of I don't know what I don't know, right? You want to come in, you want to learn. Click the link below and find out more about the mentorship program. All right, I'll see you inside.